Okay. Sorry for the delay. All right. Let's begin. Who's the first presenter? Tafadhal.
I'm the first presenter. I will share my screen. You can see my screen, right? So I will begin. So we begin. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Maria binti Abu Samah. My group and I will be presenting seminar about genetics. So this is our subtopics. I will present about molecular basis of genetics, followed by autosomal disorders by Nurul Sufiana, then sex-linked disorders by Wan Umairah, and chromosomal disorders by Muhammad Najmi. So into the first subtopic, molecular basis of genetics. This is my outlines, introduction, chromosome, gene and allele, DNA, mutation, and importance of molecular genetics. So a little bit of introduction. Genetics is the study of heredity and of the mechanisms by which the genetic factors are transmitted from one generation to the next. Molecular biology is the field of biology that studies the composition, structure, and interactions of cellular molecules, while molecular genetics is the field of biology that studies the structure and function of genes at molecular level. The human body is composed of cells. Most cells in the human body contains a nucleus, and in the nucleus are the thread-like units called chromosomes. And these chromosomes are made up of thousands of genes. A gene contains a sequence of DNA that carries information or instruction on how to make a specific protein inside the body. So chromosome, what is chromosome? Chromosome is fine thread-like structure of nucleic acid and protein found in the nucleus of cells. It carries the genetic information in the form of genes. And one chromosome consists of two identical chromatids and a centromere. Centromere is the constricted point of the chromosome that separates the short arm called P arm and the long arm called Q arm. And each chromatid contains one DNA molecule. In human, there are 23 pairs of homologous chromosomes, 22 pairs of autosomes, and 1 pair of sex chromosomes. The autosomes will determine the characteristics such as eye color and height, while the sex chromosomes will determine gender. In a pair, one chromosome is inherited from each parent, so 46 chromosomes in each individual. 23 is inherited from each. Gene is a segment of DNA that codes for a particular protein or trait. Gene is found on a particular location on a chromosome called a locus. So in a chromosome, there are many loci. So each locus locates a gene that codes for a particular trait. For example, eye color gene is localized in chromosome 16, while hair color gene is localized in chromosome 6. Eye color gene in chromosome 15 and hair color gene in chromosome 16. Alleles is the genes found at the same locus on homologous chromosome, which control the same characteristics. There are two types of allele, which is dominant and recessive. For example, here, individual A has big E and small e alleles. Big E is allele for brown eyes, which is a dominant allele, while small e is allele for blue eyes, which is a recessive allele. If a person has different types of allele, he is called heterozygote. The dominant allele is the one that will determine the characteristic of or phenotype of the person, which is in this case the eye color. So individual A will have brown eye color, while for individuals with same types of alleles, they are called homozygote. His phenotype will be determined by the allele that he has. Next is DNA. DNA stands for deoxyribonucleic acid. It is a polymer of nucleotides covalently linked by 3N to 5N phosphodiester bonds. It consists of three basic components, which is deoxyribose sugar, phosphate group, and also nitrogenous base. Nitrogenous base can be adenine, guanine, cytosine, or thymine. These three basic components will make up a nucleotide. The nitrogenous bases is where the information in DNA is stored. These DNA bases will pair up with each other, where A pair up with T and G pair up with C. The nucleotides are arranged in two long strands that form a spiral called a double helix, and both strands run in opposite directions to each other, known as antiparallel, where 5N where 5N of a strand is paired with the 3N of its complementary strand. There are two functions of DNA, which are replication and transcription. So, replication is where the DNA makes a copy of itself during cell division to provide the progeny or daughter cells with the genetic information processed by the parent, while transcription is the process of synthesis of RNA that will serve as the source of information or the blueprint for the synthesis of all protein molecules of the organism. So, this is the steps for DNA replication. First, helices will unwind the parental double helix. Then, single-strand binding proteins will stabilize the unwound parental DNA. The leading strand is synthesized continuously in 5N to 3N direction by DNA polymerase. The lagging strand is synthesized discontinuously. Primase synthesize a short RNA primer, which is extended by DNA polymerase to form an Okazaki fragment. After the RNA primer is replaced by the DNA ligase joins the Okazaki fragment to the chromosome strand. And this is the direction for the replication. While for RNA transcription, transcription use one of the two DNA strands as a template, which is the template strand. Here, the template strand. The RNA strand the RNA strand is complementary to the template strand, so it is almost similar to the other DNA strand, which is the coding strand, except that the timing will be replaced. The timing in DNA will be replaced by uracil in RNA. To begin transcribing a gene, RNA polymerase binds to DNA of the gene at a region called the promoter. Once RNA polymerase is in position at the promoter, the next step, which is elongation, can begin. During elongation, the RNA polymerase moves along the template strand in the 3 to 5 direction, in the 3N to 5N direction. For each nucleotide in the template, RNA polymerase adds a complementary RNA nucleotide to the 3N of the RNA strand. Then, termination happens once the polymerase transcribes a sequence of DNA called terminator. This is where the additional adenine nucleotides are added to the 3N of the RNA transcript, or this process also known as polyadenylation. So, after the transcription, the RNA needs to undergo RNA splicing, which is a process that removes introns and joins the exon in the primary RNA transcript. Exon is the coding region that corresponds to a sequence of amino acids, while introns are the non-coding region. They are just the intervening sequences, and they do not become the part of amino acid. This process is catalyzed by spliceosome. This process is important to enable the primary transcript of RNA to become a mature mRNA transcript for the next process, which is translation. So, mRNA translation is the process where the amino acids from mRNA are decoded to produce a specific amino acid chain, or polypeptide. Before we go to the steps, let's know what is codon. Codon is a sequence of 3 DNA or RNA nucleotides that corresponds with specific amino acid or stop signal during protein synthesis. In a straight RNA or DNA strand, there are many nucleotides, right? So if the sequence of nucleotides is UCU, then it will correspond to amino acid serine. If UAU, it will correspond to tyrosine, yeah, and so on. So that is codon. Going back to translation, there are three steps of translation, which is initiation, elongation, and termination. During initiation, the components of the translational apparatus come together with an mRNA and a tRNA that carry the first amino acid binds to the start codon. During elongation, the amino acids are brought to the mRNA by tRNA and are added one by one to a growing polypeptide chain. During termination, a stop codon in the mRNA is recognized by a protein release factor, and the translational apparatus comes apart, releasing a completed polypeptide. The translational apparatus here is the ribosomal subunits. So into the fifth part of my presentation, which is mutation. So mutation is the permanent changes in DNA. It can affect a single nucleotide pair or larger chain segments of a chromosome. It is caused by environmental factors such as chemical radiation and UV light, or error made during meiosis and mitosis, which will result in replication error. There are three classes of mutation: genome mutation, chromosome mutation, and gene mutation. So we'll go this one by one. First is genome mutation. Genome mutation means loss or gain of whole chromosome. It will give rise to monosomy or trisomy. So in this picture, the patient lost one chromosome at one X chromosome. So the karyotype is only 45X. This is also known as Turner syndrome. While in this picture, there is trisomy 21, or also known as Down syndrome. In chromosome mutation, there is rearranged genetic material. It will give rise to visible changes in chromosome structure. There are 4 types of chromosome mutation: deletion, duplication, inversion, and translocation. Deletion removes a chromosomal segment. Duplication repeats a segment. Inversion reverses a segment within a chromosome. Inversion must be in the same chromosome, but it can happen in same arm, like in this picture, or between different arms. It can also change C and G. Translocation moves a segment from one chromosome to another different chromosome. The mutation is gene mutation. Gene mutation, there are 3 types of gene mutation: point mutation, frameshift mutation, and also trinucleotide repeat mutation. So point mutation is the substitution of a single nucleotide base by a different base, resulting in the replacement of one amino acid by another in the protein product. So there are 3 types of point mutations. The first one is silent. In silent mutation, the base is changed, but the amino acid is not changed. In missense mutation, the base is changed and the amino acid also changed. But there are 2 more types of missense mutation, which is conservative and non-conservative. In conservative mutation, the mutation will affect the function, but only a minor. Will only cause minor effect, but for non-conservative, it will cause big effect, such as sickle cell anemia. It will change the shape of the protein from RBC from the it will change the RBC shape into sickle shape. Sickle cell shape. The third point mutation is nonsense mutation, where a change in the base will a change in the base that used to for an amino acid is changed into a stop codon. Next is frameshift mutation. Frameshift mutation is the insertion or deletion of nucleotides that alters the reading frame of DNA. So, for example, here is cystic fibrosis. There is deletions. There is deletion of three nucleotides from the coding region of a gene. So this will cause loss of phenylalanine at the 508 position. The third gene mutation is trinucleotide repeat mutation. It is characterized by amplification of a sequence of three nucleotides. For example, in Huntington disease, there is repeated trinucleotide CAG. So this repeated trinucleotide, adds a string of glutamines into the protein. And the last part of my presentation is the importance, just 3 points. The importance of molecular genetics. It will give insight or understanding into the heredity, genetic variation, and also mutation. It is also important for the diagnosis and management of genetic disorders, and also to identify genetic disease carriers to provide them with genetic counseling. Okay, and this is my references. That's all.
Okay, that's a very interesting presentation. That's good. Okay, my question to the others and also to the presenter as well. Okay, I think what you have presented is basically just the theory part. So my question is, Allah mentioned, "Walaqad khalaqnal insana fi ahsani taqwim," isn't it? Allah have created all mankind as a perfect being, as a perfect creation. So how do we explain that some of them has even at the basis of it, at the crux, the DNA of it is abnormal? Is it some Allah created perfect and some is not perfect? Is it against what Allah mentioned in the Quran? Faham tak soalan tu? So how do you explain? Sana, anyone? Anyone has any idea how to explain this?
Perhaps, perhaps the definition of perfect by Allah is the same definition of perfect by man. Which means that if Allah did with genetic
I can't hear lah. Siapa yang cakap ni? I can't hear. Tak apa ni, bunyi pecah-pecah.
Maria, I'm speaking.
Oh, you're the presenter, is it? Ke pecah-pecah? I don't know why. Is it my line probably? Okay. Again. So you think can you try explaining again? Sorry. I hope it's better now.
I think this is my opinion. I think the definition of perfect for Allah and definition of perfect for human is different. So if a person is born genetically or is the image is perfect or he perhaps not see it, but Allah has written or perhaps.
I seriously don't understand what you said just now. When you presented earlier, it was very clear, but now I don't understand. Okay, fine. It's okay. It's all right. Okay. I have asked this question when I was a medical student in 2008, I think. So there was a long time ago. I asked to one of our lecturer, Prof. Omar Hassan Kasule. So I asked him, Allah mentioned, "Laqad khalaqnal insana fi ahsani taqwim." Allah created human being is a perfect creation. So is it that some Allah created perfect 46 chromosome and some has defects? Some Allah make it not perfect. So he answered in a very nice way. He answered like this. So he said, it's almost like a child that has an accident at childhood. So a child had an accident and then loses one of his limb, for example, isn't it? A child lost his finger, lost his thumb, lost his limb. You don't call that as an imperfect creation. The original creation is perfect, but the child had an accident that causes the abnormality. So this is the same even through chromosomal defect. The original creation is perfect. Ahsani takwim, perfect creation. But throughout the process, even during conception and so on and so forth, throughout the process, there are events that causes all this mutation and causes all these abnormalities, causes the deletion, causes the insertion, causes whatever problem. So these are all events that occurs throughout the process, because life does not begin when we are given breath. The life begins much earlier than that, even from conception and so on and so forth. So this is part of ourself as a being. So the injury occurs during conception. The injuries occurs during the process from when we from just two chromosome, and then we become a zygote, then become a fetus, and so on and so forth. So it is an injury. It is like, because the presenter mentioned already. So all these issues can happen because of environmental, can be because of many external factors. So the answer is that original creation that Allah has created is perfect. The imperfect is the accident, the injury that occurs. The kias is, we kias as a child that had an accident. So you don't call that as an imperfect creation, but it is a perfect child that had a event, that had a accident that causes the abnormality to happen. Okay, right, fine. Let's go to the next presentation.
Can you see my screen?
Yes, we can.
Okay.
Yes.
Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Sutyana, and now I'm going to talk about the second topic under genetics, which is the autosomal disorder. So here is the outline of my presentation. First, I will talk about the different class.
Your slide is not moving.
Oh, so. So. Gerak tak?
Now yes.
Okay. 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 First, I will talk about the different classification of genetic disorder, and then into the autosomal disorder, the definition, the overview, and the three examples of both autosomal dominant and autosomal recessive disorder. So, first, the classification of genetic disorder. Genetic disorder can be classified into 5 different groups, which is the first is single gene mutation, second is chromosomal disorder, and next is condition that are caused by exposure to teratogen. Next is multifactorially inherited condition, and lastly is disorder that show an unusual pattern of inheritance. Okay, so under the single gene mutation, is the autosomal dominant disorder and autosomal recessive disorder, which I will talk about, and also X-linked disorder. Okay, so what is actually meant by autosomal disorder? Okay, autosomal disorder, as we have learned that humans have diploid genome that contains 22 pairs of autosomes and 1 pair of sex chromosomes, each that we get from our parents. So autosomal disorder is a disorder that is caused by mutation in the genomes of the autosome or the numbered chromosome, which is number 1 from 22, or also called as non-sex chromosomes. Okay, autosomal disorder can be divided into autosomal dominant disorder and autosomal recessive disorder. I will talk first about autosomal dominant disorder. In autosomal dominant disorder, a single copy of gene bearing a mutation is sufficient to cause a disease, which means that the condition can also occur in heterozygous. And affected parents have 50% chance of passing mutated gene to each of his child. And as autosomal dominant is autosome affects the autosome, which is the non-sex chromosome. So males and females are equally affected. And autosomal dominant disorder often affect the structural protein. Okay, sorry. Okay, as you can see in the diagram, the father is affected since he has one copy of the mutated gene, and the children get chromosome from each of the parent. Hence, the child of the affected father has 1 in 2 chance of being affected. Okay. Some carriers of a mutation may not show clinical signs of the disorder. But other people who have the same mutated gene can manifest symptoms, and this is what we call as penetrance. So, if one disease, all individual that carry mutation from one disease of the autosomal dominant disorder show the signs of disorder, then the gene is said to have complete penetrance. So there are potential reasons for different penetrance for different disease. There are modifier gene, environmental factors, age, and gender. Okay. Often autosomal dominant disorder show variability in symptom expressed in different individuals carrying the same mutated gene, meaning that some may show mild clinical symptoms while others have severe disease even though they have the same mutated gene. So this is what we call as variable expressivity. Autosomal dominant disorder can also sometimes occur in a child of unaffected parent because of spontaneous mutation. This case is not to be associated with advanced paternal age, which means that the parents are older than 35 years old. Okay, one of the example is achondroplasia, which I will talk about later, which approximately 80% of the patients who suffer from achondroplasia have spontaneous mutation. Okay, these are the examples of autosomal dominant disorder, and the first three I will talk about the first three. Okay, the first achondroplasia, the first autosomal dominant disorder is the achondroplasia. It is the most common cause of dwarfism, and it is caused by a defect in the cartilage-derived bone. Okay, achondroplasia is caused by mutation in the FGFR3, which is the fibroblast growth factor receptor. This is on the chromosome 4, which code for the FGFR3 protein. This is the FGFR3 protein. So when FGFR3 protein binds to FGF, which is fibroblast growth factor, it will slow down the growth of certain bone. So when mutation happen, FGFR3 gene when mutation happen to FGFR3 gene, this mutation happen. It will cause the FGFR3 protein, this one, to be constantly active, or in other words, the mutation makes this receptor to behave as though it is binding to the FGF, even when it's not. So when it behaves as it is binding to the FGF, so it will slow growth and leading to inhibition of bone growth. So that's why it leads to dwarfism. Okay, so more specifically, FGFR3 that is always active cause chondrocyte at the growth plate to proliferate slowly and become disorganized. This will lead to endochondral bone formation. This will lead to impairment of the endochondral bone formation, which is the process of bone elongation. Okay, so when mutation happen, bone cannot elongate. So bone cannot elongate because it is inhibited. So the result, there will be growth restriction, bone shortening, and skeletal anomalies. So the bony abnormality in achondroplasia will lead to short stature, macrocephaly, a flat mid face with prominent forehead, and rhizomelic shortening of the limb. So these are the feature of individuals suffer from achondroplasia, or also called as dwarfism. Okay, next is neurofibromatosis type 1. It is one of the most common autosomal dominant disorder. Okay, it is caused by a mutation in the gene NF1, which code for protein neurofibromin, which is also a tumor suppressor gene. The expression in neurofibromatosis type 1 is extremely variable. So many people have features so mild that they are never diagnosed. So cardinal features of neurofibromatosis type 1 are the Kefi-Aule spots, axillary or inguinal freckling, which you see in the picture, leash nodule, and cutaneous neurofibromas. The last one for autosomal dominant disorder is the Marfan syndrome. Marfan syndrome shows pleiotropy, in which that it is a condition abnormalities in multiple organ system are caused by mutation in a single gene. Means that in this Marfan syndrome, multiple organ system are involved. So, okay, Marfan syndrome is caused by a mutation in the FBN1 gene, which provide information for making fibrillin 1. The clinical symptoms mostly involve three systems. As I mentioned before, that this Marfan syndrome involves many organ systems, but these are the three systems that commonly involved, which are the cardiac, ophthalmologic, and skeletal. Normally, interstitial space of various body tissues is full of microfibril, which is formed by fibrillin 1 and fibrillin 2. Microfibrillin are the strong rope-like structure that provide tissue integrity and form connective tissue. Also, in some structure, microfibrils can form additional proteins like elastin, which give tissue a rubber band-like quality that allow tissue to stretch and go back to their original shape. Other being part of microfibrils, fibrils can also regulate tissue growth. Fibrillin remove TGF-beta, which stimulate tissue growth. Hence, the presence of fibrillin will lower the amount of TGF-beta available to stimulate tissue growth. So in Marfan syndrome, fibrillin is either dysfunctional or less abundant, result from mutation. So this will lead to fewer functional microfibrils. So when less microfibrils, then less tissue elasticity and tissue integrity. Also, in addition to that, TGF-beta also will not get removed, so it will cause excessive of TGF-beta signaling, meaning that it will be more tissue growth, because TGF-beta will slow down growth. So when it is not get removed, there will be more growth. Okay, the most obvious physical feature of Marfan syndrome involve the skeleton. So individual will have the long bones of the individual will grow excessively. So individual are tall with long arm and legs, and this is called Marfanoid body habitus. And this is the features of Marfanoid body habitus. Okay. Also this. Okay, next under autosomal disorder is autosomal recessive disorder. This disorder manifests only when both copies of gene pair located on a non-sex chromosome have a mutation, which means that it is only occur homozygously. So affected children usually are born from unaffected parents, each of the parent who carries one copy of the mutation, which means that the affected children, their parents are not affected, but their parents are the carrier of the disease. So okay, the risk of this disorder is increased by consanguinity, which is marriage between cousins, and also within specific population. While the autosomal dominant usually affect the structural protein, autosomal recessive usually affect metabolic pathway. These are the examples of autosomal recessive disorder. And I will talk about the first two. Okay, the first one is the sickle disease. The mutation is in the beta globin chain, causing the hemoglobin to become abnormal, or specifically called sickle hemoglobin or HBS. So in sickle cell disease, red blood cell can carry oxygen well, but under deoxygenated state, the red blood cell will adopt the sickle shape due to the intracellular polymerization of HBS, in which the HBS will become insoluble and form crystal. This causing the red blood cell to become less flexible and more adherent to vascular endothelium. Sorry. Okay. Okay. The intracellular polymerization can be reversible upon reoxygenation at first, but with repeated cycling, the process will become irreversible and there will be also membrane damage. Okay, this is the picture of our sickle red blood cell. Next one is the cystic fibrosis. Cystic fibrosis is the most common life-limiting genetic disease in the white. Cystic fibrosis develops when there is mutation in the CFTR gene, which stands for cystic fibrosis transmembrane conduction regulator, and this CFTR gene code for CFTR protein. Okay, this is the CFTR protein. CFTR protein is a chloride channel found in surface epithelial cells. It is important for proper movement of salt and water across the membrane and maintain appropriate composition of various secretion, especially in the airways, liver, and pancreas. So what this CFTR protein does? It will pump chloride ion. It will pump chloride ion into various secretion. And this chloride ion will help to draw water into secretion, which ends up thinning the secretion. So when there is mutation in the CFTR gene, it will lead to the absence of CFTR protein on the epithelial surface. This means that when there is no CFTR protein, chloride ion cannot be pumped. Chloride cannot be pumped out into the secretion, which then water cannot be drawn in and the secretion will be left overly thick. So, okay. The abnormal CFTR result in the clinical manifestation of cystic fibrosis, which include excessively high sweat sodium and chloride test in the sweat gland. So this high chloride and sweat sodium will be tested by sweat chloride test, which is the standard diagnostic test for cystic fibrosis. Other than that, the abnormal airways due to the mutation of the CFTR gene will also make the airways more prone to colonization of bacteria and reduce function of airway defense, which will all lead to the bronchial damage. So that's all, and this is my references that I use for my topics. So any question?
Any questions from the group? Any questions to the presenter? Okay lah, quite clear lah. I think it's quite a good presentation. Okay. All right. If there's no question, let's proceed with the next.
Ya, Assalamualaikum warahmatullahi wabarakatuh. My name is Wan Umairah binti Wan Muhammad Yusuf, and today my topic will be about sex-linked disorders. And here is the outline of my presentation, which are what is sex chromosome, sex-linked pattern of inheritance, and sex-linked disorders. So we go to the first part, which is sex chromosome. In human, the sex chromosome is the 23rd pair of human chromosomes, while the other 22 are called as autosomes. And sex chromosome is a type of chromosome that participates in sex determination. For individuals having two X chromosome or XX in their cells are female, while male has one X chromosome and one Y chromosome or XY in their cells. So the X chromosome is larger than Y, so it carries many more genes than the Y. Now we go to the second part, which is sex linked pattern of inheritance. For sex linked pattern of inheritance, it is divided into two, which are X linked and Y linked. For X linked, it is divided into two, which are X linked dominant and X linked recessive. Okay, so we go to the X linked dominant. For X linked dominant, the gene controlling the trait must be located on any one of the X chromosome to be expressed. And here are some criteria for X linked dominant. First, there is no carrier status. This is because the person who has the dominant gene will always have the disease, so there is no carrier status. And the second, the trait appears in every generation. Like you can see in the picture, the black one is the one who has the disease, and so it appears in all generations. For another criteria, I will explain on the next slide. For the left picture, the mother is affected, but the father is unaffected. So if the mother is homozygous, the risk of having an affected child is 100% with each pregnancy. And if the mother is heterozygous, the risk is 50%. Like in the picture, the mother is heterozygous. For the right picture, the father is affected, but the mother is not. In this situation, the daughters are all affected or 100% risk, and sons are unaffected or 0% risk. This is because the father only give the X chromosome to his daughters, while the sons get the X chromosome from the mother. So we go to the X-linked recessive. For recessive pattern, the gene controlling the trait need to be located on both of the X chromosomes in female and only on one X for male. A typical X recessive pattern meets the following criteria. First, the expression of the trait is much higher among males. This is because in female, they need to have the gene on both X. While male, when he gets the recessive gene on is only one X chromosome, he will get the disease. And for the next criteria, again, I will explain using the next slide. For the left picture, the mother is a carrier and the father is unaffected. So the carrier mother have a 50% risk of transmitting the gene to their offspring. And daughters who inherit the trait are carriers, while the sons who inherit the trait are affected or will get the disease. For the right picture, the father is affected, but the mother is not. The trait cannot be transmitted from father to son, but the transmission of the traits occurs from father to all daughters because the father will give his one X chromosome to his daughters. As we go to the Y-linked inheritance, for Y-linked inheritance, the trait encoded by gene...
Presenter, you're going to give example, isn't it? Are you going to give example?
After this.
Of all? Okay, all right. Okay.
Okay, for Y-linked inheritance, the trait encoded by gene on the Y chromosome are passed directly from father to son. And for the criteria, only males are affected because females do not have Y chromosome. And second, mutated alleles on the Y chromosome are always passed on from the father to the son. So the son is always affected. And the third, affected father cannot transmit the gene to his daughters because females do not have X chromosome. And now we go to the sex-linked disorder.
Female don't have Y chromosome. You said female don't have X chromosome.
Sorry, because females don't have X chromosome. Females don't have Y chromosome. Okay. Now we go to the sex-linked disorders. Actually, there are a lot, but I come with some examples. For X-linked dominant, I'll be explaining about X-linked hypophosphatemia, incontinentia pigmenti, fragile X syndrome, and RETT syndrome. For X-linked hypophosphatemia, it is a disorder characterized by low levels of phosphate in the blood. And the characteristic can be short stature, rickets, tooth abscesses, osteomalacia, which is the softening of the bone and joint pain, where the bone and joint pain can be seen when the child involved in physical activities, and also gait abnormalities. Another characteristic can be decreased renal phosphate reabsorption and decreased intestinal calcium and decreased intestinal calcium and phosphate absorption and decreased renal phosphate reabsorption. So when the blood levels of phosphate become abnormally low, the bone mineralization becomes impaired, thereby will lead to the weakening of the bones and lead to osteomalacia. Next, we go to incontinentia pigmenti. It is a disturbance of skin pigmentation and sometimes associated with the malformation of the eye, teeth, skeleton, and other systems. So some of the characteristics are the major features can include vesicular and pigmented macular lesions. For the skin, they will have vesicles on the extremities, trunk, but sparing the face. And for the eyes, can have strabismus, congenital cataract, and retinal telangiectasia. For retinal telangiectasia is when the tiny blood vessels in the macula grow in abnormal way and it become dilated and leak. And for CNS, there will be mental retardation, microcephaly, where the child head is small, or hydrocephalus, or accumulation of CSF. And the child also may have congenital missing and malformed teeth and also breast hypoplasia. Next, for fragile X syndrome, it is a disorder in which an unstable region on the X chromosome contains abnormal number of DNA base pairs. So this is the most common form of inheritable mental retardation. And for the characteristic, the child may present with mild cognitive and behavioral deficits, moderate to severe mental retardation, long thin face, large ears, prominent jaw, and post-pubertal macroorganism where the males have large testes. And also, the child may have hand biting, speech disorders, and tactile defensiveness, which is when the person is very sensitive to touch. And in addition, as in the picture of the hand, hands, the patient may have hyperextensible joint. Next, we go to the Rett syndrome. It is a disorder which almost exclusively affects girls, and this is due to the alteration of gene on chromosome S. This gene controls a protein which is important for the normal development of nervous system. So when there is impair in the development of nervous system, the child may present with mental retardation, severe gross and fine motor handicaps, epileptic seizures, and epileptic seizures are quite common. And which also may have breathing irregularities and intestinal disturbances due to the disturbances of autonomic nervous system, scoliosis, and severe communication disabilities. So in the picture, the children with Rett syndrome, they tend to have unusual eye movement such as intense staring, blinking, cross eyes, or closing one eye at a time. Also, they sometimes make sudden odd facial expressions. As we go to the X-linked recessive disorders, the examples are red-green blindness, hemophilia, G6PD deficiency, and Duchenne muscular dystrophy. For red-green blindness, it is a disorder due to the photopigments of the eyes or red cones or green cones do not work properly. So here are the type of red-green blindness, deuteranomaly, where the green cone doesn't work as it should, so the yellow and green color will look redder. The second, protonomaly, where the red cone photopigment doesn't work as it should, so the orange, red, yellow look greener and colors are less bright. And for protanopia, you have no working red cone cells, so the color the red color will look dark gray. And lastly, the deuteranopia, where you have no working green cone cells, so the reds may look brownish yellow and greens may look beige. Then we go to hemophilia. It is a group of blood disorders in which there is a defect in the clotting mechanism, and the most common hemophilias are hemophilia A, which is the deficiency of factor A, and hemophilia B, which is the deficiency of factor 9. And the characteristic, the child may present with easy bruising when crawling and walking, which is during 9 to 12 months age, hematrosis or bleeding in the knee joint, epistaxis, gum bleeding, hematuria also occur and the bleeding may occur spontaneously after trauma, operation, or dental procedures. Next, we go to the glucose phosphate dehydrogenase deficiency or GSPD deficiency. It is a abnormality, a genetic abnormality that results in inadequate amount of G6PD enzyme. So G6PD enzyme is an important factor in protecting the red cells against hemolysis. So in the child who have glucose phosphate dehydrogenase deficiency, they need a vitamin K and vitamin C in excessive doses can cause damage to RBC, and they also must avoid fava bean or broad bean. So the characteristic that may happen after taking the triggering factors such as rapid heart rate, shortness of breath, urine that is dark or yellow orange, fever, and jaundice. And next is the Duchenne muscular dystrophy. It's when the skeletal muscles are more fragile than normal muscle. So the weakness start to appear when a significant part of skeletal muscle has degenerated and been replaced by fibroadipose tissue. So the characteristics can be delayed intellectual milestones, delayed speech development, failure to thrive, and also Gower sign. So for Gower signs, like in the picture, it is a result from weakness in the child's proximal hip muscles. So when the child want to get up from a sitting or supine position, they need to prone on the elbows and knees, and then they need to they need the knees and elbows are extended to raise the body. And lastly, we go to the Y-linked disorders, which are retinitis pigmentosa and hypertrichosis. For retinitis pigmentosa, it is a term for a group of eye diseases that can lead to loss of sight. And the characteristics, the earliest symptoms that can be detected such as night blindness, poor or constricted visual fields, bone spicle-like pigmentation of fundus, like in the picture, where there's the shape like speckle types, like the speckle in the pigmentation of fundus. And also the evidence of photoreceptor cell dysfunction, and also photophobia, which is sensitive to light. And lastly is hypertrichosis. It represents the growth of hair in an excessive amount. The vellus hair, which is the hair that is thinner than other hair, it will continue to grow and reach up to 10 centimeter length on the entire body surface except the palm soles, dorsal surface of distal phalanges and clypeus. And the characteristics such as associated dental abnormalities, defects of the ear, photophobia, and physical and mental retardation. But for physical and mental retardation is rare. So here are my references, and I think that's all for me. Is there any question?
We have another topic, another presenter, is it? How many more presenter after this?
One.
One more. Okay, one more. Okay, all right. X-linked diseases, X-linked and Y-linked diseases. These are another. Okay, fine. I think I'll comment after the last presenter. Okay, all right, fine. Any question? Any question from anyone else?
Assalamualaikum. I have a question.
Yep. Proceed. Shoot.
In the picture of apple in the slide of red green blindness, what do you think about the type of blindness of that picture?
Mana presenter? What was the question again? What is that?
What is the type of color blindness in that apple picture? For the apple picture.
Okay, let's get the presenter to answer. Mana presenter? Come.
Umaira, you on mute.
Sorry to mute. Okay, I think for the type, the patient may have deuteranopia, which is no working green cone cells. So if you can see the red apple look brownish yellow and the greens may look beige, I think. That's all.
Okay, thank you.
Green.
Yep, good answer. That's correct.
Next.
Okay, this was the last presenter.
Yeah. Version of slide. Okay, for the last part of the genetic seminar presentation is chromosomal disorder. So I will present about chromosomal disorder. So first we go to the definition of chromosomal disorder. It is an error that occurs in meiosis during the production of the gametes, in which it can lead to the abnormality of the chromosomes structure or the chromosome number. Any changes in the number of the chromosome or the structure will give rise to many problems in the growth, development, and also the function of the body system. So under the chromosomal abnormality can be divided into numerical and the structural abnormality. For numerical, we have aneuploidy and polyploidy. And for the structural, we have duplication, deletion, inversion, and translocations. Under the aneuploidy, the numerical abnormality, we have trisomy, such as Down syndrome, trisomy 21, Edward syndrome, trisomy 18, and also Patau syndrome, trisomy 13. And for monosomy, we have Turner syndrome. Okay. First, we go to the first trisomy, the first chromosomal abnormality under the numerical abnormality, which is the Down syndrome, trisomy 21. It is a syndrome associated with the presence of extra chromosome in the chromosome 21. It is the most common chromosomal abnormality worldwide. As it occurs in 1 of every 1,000 live birth. Okay, what causes this to happen in cytogenetically? Mostly because of non-disjunction. What we mean by non-disjunction is inability of the chromosome to separate during the meiosis 1 or meiosis 2. And thus, the extra chromosome 21 may result from the meiotic process. And also there's 5% of them are made causes by translocations, in which when the long arm when the long arm of the two different chromosomes diffuse together and the short arm of the chromosome is lost. It is usually affected at the chromosome 14. There's also another chromosome such as chromosome 15, 20, or 21, but commonly is chromosome 14. And also for the risk factor of the Down syndrome, first is the older maternal age. As we can see, as when the maternal mother increases in ages, they have higher risk of having child with Down syndrome. And another other risk factor is parent or mother who have already having a child with Down syndrome, so it can have recurrence the other child can also have Down syndrome. And also the third risk factor is the parent who are carrier of the genetic translocations. And next, we go to the clinical feature of person with Down syndrome. Basically, they have a typical craniofacial appearance, such as round faces, flat nasal bridge, and also up-slanted palpebral features, epicanthid fold, and small mouth and protruding tongue, small ears, and also flat occiput. The other anomalies are short neck, single palmar creases, incurve and short fifth finger, and wide sandal gap of the between the first and the second toes. As you can see from the picture, the middle picture is single palmar creases, or in other words, simian creases, and at the right side is sandal gap, which the first toe and the second toe is there is gap. And the first picture at the left side is the posture of uh, newborn baby with Down syndrome is hypotonia. And Down syndrome also affected other multiple systems, such as first in cardiologically, a person with Down syndrome may presented with endocardial cushion defect, AVSD, atrioventricular septal defect, and also VSD, ASD, PDA, and TOF. For next is gastrointestinal system. They have problem with their GIT, like presence of duodenal atresia or stenosis, as you can see, and other like annular pancreas, tracheoesophageal fistula, and Hirschsprung disease. And later, they can also develop other multiple problems at another other systems, such as in for CNS, they have mental retardations, and they have also tend to have early Alzheimer disease, and also have hearing impairment. For the immunological system, they have impaired cellular immunity, and which leads to high incidence of infections, and also autoimmune disorder and malignancy. For the musculoskeletal, they have hypotonia, and also risk of atlantoaxial instability, and last is endocrine system. They have hypothyroidism, and also can develop type 1 diabetes mellitus and celiac disease. And for the developmental part, the development and growth, they have delayed development, having learning difficulties, and also generally they have a small stature compared to with a normal child. So this is the list of the clinical features of child with Down syndrome. And this is just a mnemonic to help for memorizing the clinical features. Child has problems, C, congenital heart disease, H, hypotonia, and the list goes on. And for the making diagnosis to make a diagnosis, we have antenatal screening. First is blood sampling, and also radiologically we can do an ultrasound. Okay, from the ultrasound we can see the presence of nuchal fold thickness that is more than 3 millimeter, and the right image is double bubble signs, which indicates presence of duodenal atresia. And next is amniocentesis and coronary villus sampling. If from the blood test we do, the result test is abnormal, we can proceed with the diagnostic test, which are this amniocentesis and coronary villus sampling. Amniocentesis usually done at 16 to 18 weeks at the early second trimester. It basically we use a needle to take fetal cell from the amniotic fluid. And for the coronary villus sampling, we use suction tube. Suction tube is used to remove part of the fetal cell from the chorion, where the placenta develop. And then we do from the sample, we take it to make karyotyping to diagnose Down syndrome. Next, we go to the management part of the Down syndrome. First, we perform examinations to the patient to look for any associated complications. And for the health surveillance and monitoring as displayed by the table, like thyroid tests, we do thyroid tests at birth or by 1 to 2 weeks of life. And we have growth monitoring. They have growth monitoring, and also eye examination, hearing checkup, and cardiological monitoring. Okay, management. Okay, next part we go to the trisomy 18, which is Edwards syndrome. It is the second most common trisomy with the...
Wait, presenter. Okay, yeah. I just need to highlight Down syndrome is basically the most important, one of the most important chromosomal disorders lah. It will always come out in your exam. It will always come out in your exam. So you will always have Down syndrome patient for professional exam, for whatever exam. So and you need to know Down syndrome in great detail. So Down syndrome is among the disease that you need to know in great detail. Okay, alright.
Okay, okay. Next, I will proceed with the second one is trisomy 18, the Edwards syndrome. It is second most common trisomy with incidence of 1 in 7,500 live birth. More than 95% of children with Edwards syndrome are spontaneously aborted in the first trimester. Those who survive have significant neurodevelopmental delay. The clinical features of person with Edwards syndrome are low birth weight, closed fist, with index finger overlapping the third digit and the fifth digit overlapping the fourth. Narrow hips with limited abduction, as you can see. Short sternum and rocker bottom feet, as you can see, the club feet. And microcephaly, prominent occiput, micronetia, cardiac and renal malformations, and also intellectual disability. And complications that may arise is spontaneous abortion, stillbirth, apnea. Apnea is the most common causes of the patient with Edwards to die. Congestive heart failure, early infant death, failure to thrive, and mental retardation. Next is trisomy 13, Patau syndrome. It is third most common trisomy. It occurs in 1 in 12,000 live birth. It's same like Edwards syndrome. It is usually fatal. Up to 90% of them die in the first first year of life, and also survivor have severe significant neurodevelopmental delay. And for the clinical features of Patau syndrome, includes structural defects of the brain, scalp defects, small eyes, microphthalmia, cleft lip and palate, polydactyly, and also cardiac and renal malformation. And that's for the Patau syndrome, for the trisomy. Next, we go for the next category, which is the sex chromosomal trisomy, which there is 3 sex chromosomes instead of the normal karyotypic presentation. The normal one is SS and SY. It is due to non-disjunction, cytogenetic, and it is also the most common chromosomal abnormality seen in life-form infants and children. First, we go to the Klinefelter syndrome. It is basically male with lack of secondary sexual characteristic. So we give testosterone supplements if we give them to patient with Klinefelter syndrome. Their clinical features include infertility, hypogonadism with small testes, and pubertal development may appear normal. Gynecomastia in adolescent, they have tall stature, and the basic chronology of why they have delayed puberty and sexual infantilism is generally because the failure of growth and maturation of the testes, which leads to the males with Klinefelter syndrome have testosterone deficiency, and thus make it failure to produce viable sperm, and then it will result in failure to develop later secondary sexual characteristics such as the facial hair, deepening of the voice, and also the libido. Most men with Klinefelter syndrome are infertile because they produce few viable sperm in adulthood. So for the treatment, we give androgen therapy and also treatment for infertility. For the treatment, we refer to the reproductive or infertility specialist to help them with various options for various reproductive options. Next, we go for the Turner syndrome. Turner syndrome is it basically characterized by presence of only one copy of chromosome instead of we have pair instead of a pair of chromosome. It is less common than that of the trisomy, Turner syndrome. Also the same, the occurrence is due to non-disjunction. Okay, their clinical features of Turner syndrome includes short stature is a cardinal feature of the Turner syndrome, and also they have neck webbing or thick neck, and widely spaced nipples, and they also have congenital heart defects. Mainly is coarctation of aorta. They have delayed puberty, and they can have hypothyroidism, renal anomalies, pigmented moles, and recurrent otitis media. Okay, that's for the Turner syndrome. Okay, next, let's proceed with the structural abnormalities. Okay, structural abnormalities occurs when part of the chromosome is missing or added or switch places with another part, like translocation, inversion, deletion, duplication, insertion. Okay, first is Duchenne syndrome. It is basically because of loss of the tip, or at the short arm of the chromosome 5. Hence, the
Okay,
name of
this
5
one, kriducha,
Yeah.
kriducha literally mean kri is cry. This is French. Kri, this literally means cry of the cat. So cha is cat. So this is French word lah. So kriducha. So this is a the name literally means cry of the cat. So that is why children with kriducha, they present with typical, they cry like, you know, bunyi kucing bila dia menangis kan. Exactly sounds like that. I've seen babies with kriducha.
Okay, thank you, Rata. As Dr. just mentioned, babies with Kriducha syndrome, affected babies have high-pitched mewing cry in the early infancy. But by the age of 2 years old, most of them will no longer exhibit the cat-like cry. Okay, this unusual cry, the cat-like cry, is due to the structural abnormalities of the larynx, the laryngeal hypoplasia, and also because of CNS dysfunction. The laryngeal appearance may be normal or may exhibit marked anatomical abnormalities such as floppy epiglottis, small larynx, and asymmetric vocal cords. And other clinical features include low birth weight and postnatal failure to thrive, hypotonia, developmental disability, which are similar features like autism, cleft of the lip and palate, and also congenital heart disease. The clinical severity of Kriducha syndrome depends on the size of the chromosomal deletions at the 5p. Larger deletion are associated with more severe expression of the symptom. Next, we go to maybe for the last syndrome, which are the Prader-Willi syndrome. It is characterized by hypotonia or prenatal onset early in life. The characteristic features hypotonia. Okay. When they have the affected infants are so hypotonic and that they cannot consume enough calorie to maintain their weight, thus making nasogastric feeding necessary, and failure to thrive is common if for this patient. Then during the first year of life, their muscle tone improves, and the children itself will develop a voracious appetite. I mean, they have insatiable appetite, which lead them to have obesity after infancy. And Prader-Willi syndrome also have postnatal growth delay. Okay. And the others clinical features such as for the physical appearance, we have prominent nasal bridge, small hand, feet and finger tapering, soft skin, which are easily bruised, and they have because of due to the obesity, they can have striae and okay, and that's all for the chromosomal abnormality for my part, and this is my reference.
Okay, Prader-Willi is usually mentioned together with Angelman syndrome. Do you know what's the difference between Prader-Willi and Angelman syndrome? Usually when people speak about, especially when you talk about the chromosomal bit, so Prader-Willi is usually mentioned together with Angelman syndrome. Anyone has any idea? and to some sense
Uh,
bequeath Wiedemann lah, but basically it's Angelman.
Prader-Willi because of paternal side. Angelman is maternal.
Yes. Yeah, so it's on the same chromosome, chromosome 15. So if the one that is affected, if the imprinting is from the mother, then it becomes Angelman. And if father paternal, it will be Prader-Willi. So usually when you talk about Prader-Willi, people always mention about Angelman because it's the same. It's from the same, especially in terms of chromosome. The presentation is obviously different. Prader-Willi, I think mostly we saw in male rather than female. If you see male baby fat and intellectually inhibited, and you need to think about Prader-Willi. Okay, so is this the last presentation? Do we have another presentation, or you are the last?
I believe I'm the last. Yes.
Okay, all right.
Presenter.
Okay, any question to the presenter before I say a few things. Any question to the presenter? Okay, fine. Few things everyone needs to remember. The hereditary pattern, whether it's X-linked, X-linked recessive, X-linked dominant, whether it's Y-linked, whether it is autosomal recessive, autosomal dominant, these are all favorite questions for OSCE. Favorite questions for OSCE is favorite question for even for PMP we can ask as well. So for PMP we can ask you, okay, draw typical example hereditary tree for this sort of inheritance. So in OSCE we'll draw the diagram, the family tree, and then we ask you what is the type of inheritance. Is it autosomal dominant? Is it recessive? Is it X-linked? Is it Y-linked? And then name two to three common example of this inheritance. So that's why you need to have a general idea, have a general understanding, and know some of the most common diseases associated with each type of inheritance. Okay, the next thing is there are certain diseases which commonly comes in your exam. Down syndrome, as I mentioned before, in professional exam, you will always have Down syndrome patient. Always. We will always have Down syndrome patient. In Down syndrome, they have so many clinical findings. They may have cardiovascular diseases. They may have, it's good for a developmental assessment. So you will always have Down syndrome for exam. And we do have our own Down syndrome patients. We even have our Edward syndrome patient. I think my Edward syndrome patient is now five months old, and she's doing quite okay. And yeah, I think that's the second Edward syndrome in our hospital. So we do, and again, this type of patient, they can come in your exam as well. Okay, and then diseases like Turner syndrome, Klinefelter, these are all favorite questions for exam as well. But we don't have that many patients. I don't think we have any patient with Turner or Klinefelter and so on and so forth. But it's among the favorite question. Oh, Turner syndrome is another favorite question for OSCE. Duchenne muscular dystrophy is another favorite question for OSCE. We can just draw you the Gower sign, for example, and then what is the disease and what is the sign, what is the disease, how is the inheritance. So these are all favorite questions. We do have patients with Duchenne muscular dystrophy that almost always come in professional exam every year. So you need to know this type of disease, Duchenne muscular dystrophy. What else important for genetics? I think that's all. Any questions? Any question? Okay lah. All right. I think if no other question, I think that should be okay. There's a lot of theory involved, and I think there's more reading needs to be done. Obviously, the moment when you come to your professional exam, which is still a long way to go, I assume many of you will have forgotten about all those that have been discussed by your colleagues. But at least you need to remember, you need to refresh yourself frequently. Again, these are all questions that will always come in your exam. Okay, all right. I think if there's no question, let us end our